Good day. This is the training for the CSP number 596 Operations Manual version 4, updated for the study expansion. It's highly recommended that the staff review the Operations Manual and associated appendixes before taking this training, as it is better to understand the material. If you have any questions or need further explanation, call or email the National Study Coordinator, Neil Johnson, and the CSPCC Project Manager for CSP 596, Michelle Johnson, and we'll do our best to assist you. At the end of this training, please send an email to Michelle and Neil Johnson to confirm your completion of the training. I will be skipping over some of these material as it will be more efficient for you to review them on your own, but I will provide a brief description of the material that can be reviewed and what these sections are, and we'll go into more detail for the more critical sections. Section 1 is literally going to be the purpose of the operation manual and changes to the study protocol. So you'll want to review this to get the overall theme behind the study and overall information. Section 2 is site management and procedures. This is going to list the different groups and organizations that you will be interacting with in the study and their associated responsibilities. It is suggested that you will familiarize yourself with this so you can be familiar with the different organizations and terms that you will be interacting with on a day-to-day basis as you participate in the study. This section also contains the continuation requirements and also what to do if a site study happens to be opening or closing. So it is information that you will need eventually when the study is completed. Section 3, Clinical Trials Management System and Central Study File. This is mainly going to involve SharePoint and its functions and usefulness, and that will be a training that will be conducted by Michelle Johnson. I am going to skip over reviewing protocol and procedures at this moment since we'll be going into it in greater details. With the data collection procedures, I want to specifically mention the informed consent form and the HIPAA authorization. Specifically, that both of these documents must be uploaded before you can randomize a patient. So before you can have a call for a participant, you must have these uploaded into SharePoint and iDataFax, and they must be confirmed, or you will not be allowed to continue. If you do try to continue before you have uploaded this, it will be counted as a misrandomization and would be a protocol deviation. Section 4, Protocol Procedures. Now this section is going to detail the visit schedule and the proper procedures for scheduling and managing participant appointments. The first thing that you have to worry about is appointment reminders. You'll be contacting patients regularly to remind them of their appointments. According to Operations Manual, we will contact them 2 days prior to the visit target date, but that can be at the negotiation and discretion between you and the participant. If the participant wants more calls and is fine with that, then you are free to give them as many calls as you're welcome to do. But every call you should be looking into reinforcing the stool diary and reconfirming their previous appointment, and also reminding them to contact you if they have any changes. For example, if they have any discomfort, any recurrence of diarrhea, or any changes on medication. Locating a participant, every attempt must be made to ensure the participant attends all study visits and telephone calls. The study staff will maintain a master list and a participant contact form, Appendix D forms of completion instructions for each participant. These forms should be kept separately from other participant research information in a locked drawer. For example, the participant contact CRF or the contact information needs to be kept separate from the participant binder. To have those together is a protocol violation and is potential confidentiality risk of the patient. Prior to the visit, the site coordinator will place reminder telephone calls. If a participant does not show up for the visit, the site coordinator will try and reschedule a visit within the target visit window. Attempts to contact the participant should continue daily for the first week and weekly thereafter for 4 weeks. For a missed visit, site coordinators need to submit a Form 17 missed visit to avoid the entire set of forms from being a visit being identified as overdue from the quality check reports. With missed visits, basically if for in-person visits, for the clinic visits, you are going to want to collect that information even if it is late. So even after the visit has happened, if they missed the window, you still want to collect that information just because it is required for the study. For calls, on the other hand, if you have gone past to a point where the next visit would have happened, there's no way you can make up that information and it would be considered a missed visit and you would need to complete that form. And as it says in here, you will continue to get QC reports and notifications until you have made up for those forms. Filing the missed visit form will stop those, but also it will stop as well when you add in the forms, even if they're outside the window. But if it is outside the window, you will need to complete a protocol deviation as well. During the study, it's likely that at least one participant may relocate to an area not served by the VA site at which he or she was enrolled. The relocation may be temporary or permanent. If possible, the CSP-CC will try and make arrangements to have the participant continue making study follow-up visits during the relocation, but this will depend on several factors, including the participant's willingness to continue the study, whether the new location is served by the participating site. If the participant does not want to continue, the site coordinator will need to complete Form 18, early termination. If the participant wants to continue participation, the site coordinator will notify the project manager at Hines CSPCC. If you do have any patient or participant that is going to relocate, whether or not they can continue the study is going to depend on a lot of factors. If they are already finished with study medication, it is possible to continue their participation remotely, counting on phone calls to complete the visit. It is better to try and complete the patient normally and get them to endpoint than to terminate them. If you have any questions regarding this, contact the chair's office and Michelle Johnson and myself, and we'll be happy to help you. Loss to follow-up. The site personnel should follow the above procedures for locating participants when face-to-face visits are not possible. Declaring a participant lost to follow-up should only be done in rare cases. Due to the length of the study and the frequency of the visit, the site staff should remain in contact with the participant until the end of the study. However, the participant is truly impossible to reach. For example, move to another country without providing contact information, are not reachable for 4 consecutive visits, including phone calls, and determined lost by the Hines CSPCC. Then the site coordinator will complete the Form 18 early termination and mark loss to follow-up as the reason. Before you do this, you should contact us. We will give you the final approval that you have done all steps to contact them. We will provide additional advice and a checklist, and basically check to make sure that you have done everything possible to contact them. That's including reaching them through alternate contacts and other information that may be possible. Early termination is defined as termination from the study before the follow-up period is complete. In all cases of early termination, the site coordinator will complete Form 18, early termination. Possible reasons for early termination include death, loss to follow-up, withdrawal of consent by the participant, rescission of HIPAA authorization by the participant, withdrawal by the site investigator, termination of the site or study due to low participant intake or other reasons, treatment failure assessed on day 10, achieve symptom resolution within the first 10 days but experienced a recurrence of diarrhea prior to day 90, or other reasons. With withdrawal of consent by the participant, basically they just have to say they're withdrawing consent. We can't force them to participate, obviously, so there's nothing extra that has to be done for this. Rescission of HIPAA authorization has to be done in writing, though, so if they want to rescind their HIPAA, you'll have to complete additional steps for them to do that. Withdrawal by the site investigators. Sometimes there have been circumstances where patients or participants have just not been able to continue the study due to various reasons, but it does not necessarily meet the exclusion criteria. Whether that's non-compliance or other related issues, or other conditions that might make them unable to truly be followed and confirm that that they've met endpoint. That's left at the site discretion of the site investigator, but it should have consultation from the chair's office as well. Termination of site or study due to low participant intake or other reasons. Unfortunately, if a site does get terminated, we will try and end participants normally, but we will not allow a site to continue just because they have a participant, if that will be an issue. So they may be ended early, though if a site is terminated, there will be a window of time afterwards for all information to be completed and all follow-ups to be done. So hopefully they'll be able to be completed in that time. Treatment failure assessed on day 10. If a participant starts taking study drug and shows no improvement or gets worse, it is considered a treatment failure within the first 10 days. If they show any kind of improvement, even if they have a recurrence within those 10 days, that is different. That can actually be considered a symptom resolution, even though it has happened before 10 days. If you have any questions about whether it may be a treatment failure or be a recurrence, the chair's office is happy to provide additional assistance on that. So it really depends on whether or not they've shown any improvement or not. As part of the informed consent process, an individual is told that participation in the study is voluntary and that consent to participate may be withdrawn at any time. Participant wishes to withdraw consent, the LSI must be notified. The site coordinator must complete Form 11 or Form 18, early termination. Withdrawal of consent is separate from rescission of HIPAA authorization. Rescission of HIPAA authorization must be submitted in writing per VA policy. At the study's closeout visit, if the participant's final visit will be on day 90 of the final clinic visit. If there is a recurrence of diarrhea before day 90, the site coordinator will document any unscheduled visits for recurrence or other symptoms, complications related to current diarrhea illness by completing the following forms. Form 5, physical exam. Form 8, concomitant medication. Form 9, B through D, depending on when the recurrence time is, the diary summary. Recurrence assessment, Form 11, and Form 18, early termination. One thing I do want to mention on this is we will have, while we want to see all participants in the study achieve resolution, just because we want to help people, we will have people that will have recurrences, and that is part of the study, and it is an endpoint that we are as achievable to well. So I just don't want to see anyone feeling upset just because, or feel like that they have failed a patient or they failed the study because there's a reoccurrence. If there were no reoccurrences for this study, then we would be doing something wrong and this would not be a good study. There's going to be a couple charts on the next few pages. I would recommend going to the operations manual and printing these out to have on hand, as they're very good quick reference materials. Among these is a study flow chart. The study flow chart goes over the inclusion-exclusion criteria, the study objectives, all the forms that will be done on the different days, and the different treatment arms. There's a lot of information provided in this little chart, and it is a very good quick reference material, especially for inclusion-exclusion and which forms are needed on which days. The schedule of procedures is also a very important form. It lists all the forms that will be needed as well, and other things that should be done on top of the forms, and what should be done during each visit, as well as telling which ones would be considered optional or as needed. Exclusion criteria checklist. While this is shared on some of the other forms, this is a more concise form, so it's a little bit easier to print out and have available. For inclusion criteria, all these must be yes to qualify for the study, able to provide informed sorry, I need to take a drink of water. Able to provide signed informed consent. Participant is a veteran 18 years or greater of age. Participant is confirmed current diagnosis of CDI determined by having 3 or greater loose or semi-formed stools for participants over 24 hours and positive stool assay for C. difficile. Current episode represents the first recurrent episodes of CDI within 3 months of completion of the treatment for primary CDI episodes in a patient who has not had CDI for 3 months prior to primary episode, or second recurrent CDI episodes occurring within 3 months of completion of treatment for the first recurrent episodes. To make this a little simpler, every single case occurrence of CDI that a patient has will either be a recurrence or an occurrence. If they have had no previous case of CDI in the previous 3 months, it's their first occurrence. Even if they have had CDI in the past, if it's anything, if it's as long as it's happened prior to 3 months, it's their first occurrence. If they have had CDI within the first month, then this is a recurrence. Once you identify it as a recurrence, then you have to go back 3 months from that prior. The prior case, determine if there is another case before that. If there is no case before that within 3 months, then that is their first recurrence. If there is a prior case, then this could be their second recurrence, but then you have to check from that first occurrence that's 3 months before that if there is another 3 months, because we're only allowed to do this for the first and second recurrence. If this turns out it's their third recurrence or greater, they are not eligible for the study. If you are constantly tracking the participants, you should be aware, and you, from your pre-screen log, able to know what occurrence they are, if they're a first occurrence, if this is a recurrence, or they've had multiple occurrences in the past. For female patients, is not currently pregnant or nursing, and has a negative pregnancy test at screening. If a female patient is menopausal, self-reported, this is not necessary. There is additional information in a memo of clarification that is in the appendix. Hopefully you've already reviewed that in your review of operations manual. Exclusion criteria. These must all be no to qualify. Unable to take capsules orally. If they're unable to take capsules orally, they cannot participate. So if they're on a feeding tube, they're not qualified. We're unable to do intravenous vancomycin or fidaxomicin for this treatment. Receipt of 72 hours or greater of antibiotics considered effective for the treatment of CDI, including vancomycin, fidaxomicin, metronidazole, rifaximin, or nitazoxanide. As long as you are getting to the patients immediately, as soon as you discover them, this should not be an issue. 72 hours was set, so if a potential patient comes in late Friday night, you will have at least some chance to talk to them on Monday morning. Though it is recommended that you talk to potential participants the moment you learn of them. The longer that they are from when they started treatment and they've been first diagnosed, and when you talk to them, the least likely they are going to want to enroll in the study. And we need to get with expecting to get 6 patients per year or 9 depending on your site, even losing 1, it can be very hurtful. Presence of fulminant CDI, including severe hypotension, severe ileus, or a GI obstruction or incipient toxic megacolon. Receipt of more than 1 treatment course of oral vancomycin, more than 1 treatment course of vancomycin followed by a taper or pulse, or more than 1 treatment course of fidaxomicin since the primary CDI episode as defined above. Basically, to summarize this, they are allowed to have any 1 treatment beforehand, but if they have already had 2 of the same kind of treatments, they would not be considered eligible because there is a chance that they may have that treatment again, and that would not be considered effective when this treatment has not been successful in treating them in the previous 2 times. If you are getting someone on their first recurrence, you do not need to be concerned about this because they will only have had 1 prior treatment. Even if they have started a treatment at that first recurrence, since they have not taken greater than 72 hours of it, which would be exclusion criteria number 2, it is not considered complete and would not count. So the only time you will need to worry about this is if you are looking at a patient that is at their second recurrence. Again, as always, if you have any questions, contact Michelle Johnson and myself, and we will help you understand these further or provide other input. Known allergy to vancomycin or fidaxomicin. If you do see this, has led to complications. We have seen circumstances when a patient has listed on CPRS an allergy to vancomycin, but it turned out to be a condition called red man syndrome, which is something that happens due to IVs, having a rash being on there. So the patient had received an IV of intravenous vancomycin. It was examined, discussed, and decided to be red man syndrome. After discussing with the patient was willing to participate in the study, and they were allowed to participate. So if you do see this, it is worth to do a little more digging. Acute or chronic diarrhea due to inflammatory bowel disease or other cause that would confound the evaluation and response for CDI treatment. If we cannot tell whether or not if they are showing improvement, then we are not able to have them participate. Participant is participating in another clinical trial with conflicting active drug intervention. See exceptions. We are working on exceptions for various studies. As they come up, we will continue to let you know of them. Recruitment procedures, recruitment strategies, and pre-screening. In order for this study to succeed, efficient and accurate identification and enrollment of veterans is required. Potential participants will include patients presenting a first or second C. diff recurrence. Since there is only a short window after a veteran is diagnosed to be eligible to participate, it is critical that each site develops an effective strategy to identify and respond to all potential candidates for the study. Potential strategies will need to be individualized for each institution based on site differences, but potential participants will be identified by the following strategies. Site coordinator review of hospital microbiology lab log and stool testing for C. difficile. Use of an automatic CPRS prompt announcement when a C. difficile stool test is ordered to alert the ordering clinician of the study and to notify the patient that they may be contacted about the study if the test is positive and if they potentially meet eligibility criteria. Clinical laboratory staff will be instructed to provide a recruitment letter to participants who submit a stool for C. diff testing. Using primary care providers identified during clinic visit potential eligible veterans with referrals to site coordinators. Use of VISTA reporting to identify individuals who have already had a CDI test ordered by the provider. Site-specific recruitment materials using VA, CRB approved flyers, posters, brochures will be distributed around the hospital. If local VA is a research website or newsletter, the study description should be posted. Study recruitment will be contingent on circumstances of local study sites. Recruiting to nearby VA facilities, CBOX, or clinics which have a compatible FWA reviewed annually during continuing review. What has been most successful is the combination of the automatic CPRS prompts and all the distribution of the flyers to the labs and the reviewing of the hospital microbiology lab of the stool testing for C. difficile. What this means is basically staff are completing the distributed pre-screen tracking log. Anytime there is evidence of C. diff, they track it on their log, and they check and see if there's previous information on them. If there is previous information, they update that. If there's no previous information, they add them onto the log to track them. The log also provides windows of when they'd be eligible for reoccurrence, and they can use that for continuing tracking. The flyer that is made available to the clinical lab is given to patients that have a test positive is considered a warm call to the patient. It informs of the study, so that way you are able to contact them and talk to them about the study, and it's not considered a cold call, and that is CIRB approved. If you have any questions about other recruitment strategies, we're happy always to discuss the potential possibilities and go over more details on techniques that other sites have used to be effective. Patients with positive tests for C. difficile will be pre-screened by the site coordinator to make sure there are no immediate obvious exclusions for the study. Patients who fail to be eligible during pre-screening can be documented on exclusion reasons for the pre-screening failure log. The pre-screening failure log is different from the first occurrence tracking log. The first occurrence tracking log is something that we provided as a study tool and it's not an official document. Pre-screening failure log, basically anytime there's a recurrence, you need to report it on the pre-screening failure log of saying why there was the recurrence and if they were eligible or not and why they were not eligible. Patients who are pre-screened eligible will be approached and determine interest in the study if they're currently in the hospital. If they're not in the hospital, they'll be asked to come in and complete the screening consent process. All attempts will be made to bring in the patient to the clinic on the same day or the following morning, particularly if they've been started on treatment for CDI. The written and informed consent and HIPAA authorization should be obtained prior to performance of any screening procedure. In order to be eligible for enrollment in the study, patients must pass all inclusion criteria and have no exclusion criteria as shown on Form 1 screening eligibility. Informed consent and HIPAA authorization. Informed consent must be obtained from all potential participants prior to completion of screening procedures and enrollment of CSP 596. The site coordinator at each site will introduce and explain the study to the participant and present them with a detailed informed consent and supplementary materials to read and review. Informed consent requires the participant to understand the details of the study and agree without coercion to participate in the study. After describing the study to the participant and ensuring that they have had an opportunity to carefully read and consent form, the site coordinator should ensure that any questions of the study have been answered. In addition, the participant must have an opportunity to review and discuss the study with the site team member and have any additional questions of the study answered. If after being fully informed about the study and agree to participate, then they need to provide a signature with date on the consent form. The form must be signed by the authorized study team member who administers the consent. In conjunction with the informed consent procedure, participants will review and be asked to sign the authorized receipt release for protected health information form as required by the HIPAA. The original completed and signed consent and HIPAA documents are to be placed in the participant's consent form master file. Copies of the completed signed consent and HIPAA documents are to be provided to the participant, local research office if requested by local policy, and study SharePoint site uploaded within 24 hours of enrollment. If you are not familiar with doing an informed consent with a patient or HIPAA, and there's no one you can work with to train you locally, I am happy to train you remotely. Just contact Neil Johnson. I will go over the consent with you. I will give you plenty of practice and tips on how to do that. The best thing to start with that is just to read over the consent and read over it with the patient. As you become more familiar with it, you will know which parts are important that you have to especially make sure the patient understands. Also in line with the informed consent, it must be signed, but the signature is basically, it does not have to be an active signature. If a person is going to have difficulties with a signature, a mark is acceptable as long as it is witnessed that they fully understand the consent, they've had all their questions answered, and that they are participating of their free will. Randomization and randomization assignments. If at the conclusion of visit 1 baseline screening, the participant with first or second recurrence of CDI passes all study eligibility criteria as defined by the study on screening eligibility form, the participant will be randomized into one of 3 treatment groups: a 10-day course of oral vancomycin, a 10-day course of fidaxomicin, or a 31-day course of vancomycin, which include a taper and pulse following daily treatments. All of these treatments will, even if they do not have a follow-up, as in the 31-day course of vancomycin, taper and pulse, will have a follow-up placebo card that will be done, so there is no difference between all the treatments. So basically, you and the patient will both be blinded, and you will not know which treatment they are receiving. The Heinz CSP must receive the signed informed consent, signed HIPAA authorization form, and ICF checklist within 24 hours of each randomization. The ICF, HIPAA, and ICF checklist must be uploaded to the SharePoint site under the listed directory. 3 files should have a combined and be uploaded as one document to the SharePoint site. And you'll use the following naming convention. If you have any questions additional or do not understand this, let us know, and we're happy to go over it with you further. The randomization process will consist of 2 parts to ensure the double-blind integrity of their intervention. First, dial the phone-based interactive touch-tone randomization system, ITTRS. This phone-based system at Perry Point will be your primary source for randomization into study CSP 596, which will allow randomization to take place 24 hours a day, 7 days a week. The site coordinator will call the ITTRS, enter certain of the participants' information required to randomize, and obtain a 7-digit randomization code. Second, logging onto the interactive web response system, IWRS, and obtain a drug assignment certificate using randomization code obtained from the ITTRS. I will not go over the randomization instructions, as there are training specifically for the ITTRS and IWRS that go into this in greater detail. Once a participant has been given the randomization number, the site coordinator will need to enter in the drug assignment program via SharePoint link and register one time only to request full access and set their username and password. This registration should be completed well in advance to anticipate randomization. You will have to do this in association with your training. Follow-up procedures. This section details procedures for interactions and evaluations of participant in a 90-day evaluation procedure and post-treatment. This will include guidelines for the procedures and assessment for the scheduled follow-up visits and scheduled follow-up calls, as well as procedures for unscheduled visits for recurrence. See the visit schedule tables version 2 and version 3 of this manual, and the scheduling calculator for a further reference in arranging follow-up. Scheduled follow-up calls. Participants will have 10 phone call contacts of the study during the study period to assess for potential recurrence and adverse events. Calls will be weekly, except for during weeks with scheduled clinic visits, and all calls should fall within the guidelines of the visit schedule and scheduling calculator. The primary objective of the call is to check for recurrences of diarrhea symptoms, complications of any or other adverse events, reinforce participant use of the stool diary, and obtain updates on non-study medication taken by the participant. The concomitant medication form 8 will be updated as needed during each call and kept with a participant binder. Investigators will also document participants' daily stool habits, including frequency and characteristics as reported by the participant according to the study diary. Based on the participant reporting symptoms, investigators will assess for treatment failure, symptom resolution, sustained clinical response, and/or recurrence of symptoms. Investigators should also use this time to discuss any other issues participants may have in relation to CDI, as well as to inquire of stool diary maintenance. Just a reminder, the concomitant medication is a required form at each visit, even if there is no change. You have to submit it to indicate that there has been no change. This is also used as indication that the call was actually completed. During the 4th scheduled call on day 38, investigators will complete a diarrhea and CDI reoccurrence assessment form 11, which will be sent to the coordinating center. This time point is 28 days after the treatment phase of the VANCO of all the 3 treatments arms, an important endpoint for the study. Investigators will also evaluate the participant using this form during the day 59s and day 90 clinical visit, as well as the unscheduled visit for reoccurrence. Scheduled follow-up visits. There are 4 scheduled clinic visits after the initial screening and baseline, each at set intervals from the treatment to catch all data and endpoints. Follow-up visits are scheduled at day 10 and the initial treatment phase, day 31, and the vancomycin pulse-taper treatment, day 59. Primary endpoint of the study, 28 days after treatment, and day 90 secondary endpoint, 2 months after any treatment. Follow-up visits can be held off-site if the participant has physical or social difficulties that would prevent them from traveling. The participant has given their consent to meet off-site, and the site staff are able to conduct the visit without significant burden to themselves or their duties. During the visit, the LSIs will document the stool frequency and characteristics from the study's participant study diary, assess for symptom resolution, sustained clinical response, and/or symptom recurrence of symptoms, collect participants' study diaries to confirm the reported symptoms from prior follow-up calls, to remind participants to call the site coordinators and LSIs to provide a stool sample at any time they have symptoms that can signify diarrhea recurrence, document concomitant medications at every in-clinic phone call visit, perform a physical exam in order to assess potential adverse events or toxicity from study therapy on days 10, days 31, day 59, and day 90 as needed. Document patient-centered outcome questionnaire response on Form 12. On days 10s and 31s, either the LSI or the site coordinator will order a CBC and chemistry panel to include creatine, AST, ALT, alkaline phosphates, albuminum, total bilirubin through CPRS and VISTA, and recent tests within 4 days of visit have not already been performed. During day 10 clinic visits, local site investigators will complete a treatment failure assessment, Form 10. This is only done once on day 10 after participant has finished the initial treatment medication phase. During the day 38 phone call and day 59 and day 90 clinic visit, local site investigators will complete diarrhea and CDI reoccurrence assessment, Form 11. All applicable documents, worksheets, and source documents will be placed in the participant's study folder. Required course support forms will be collected through iDataFax and electronic data collection system. Unscheduled visits, I want to clarify this is unscheduled visits for recurrence. This does not apply to an unscheduled visit if a patient just happens to show up. This is only when requested by the site staff for the patient to come in because there has been a complication or some kind of severe adverse event or recurrence that would necessitate them to come in. Participants suspected of experienced treatment failure or recurrence of diarrhea will be asked to return to clinic for unscheduled visit to verify if they meet the criteria for diarrhea and in order to submit a stool sample for C. diff testing. In the occasion of unscheduled visit for diarrhea occurrence, investigators will form a physical exam Form 5, concomitant medication Form 8, and diarrhea and CDI recurrence assessment Form 11, as well as examine and collecting the participant's diary summary. Study participants who fail to respond to any of the 3 treatment arms or have subsequent diarrhea recurrence or experience complications, including toxic medicolon, colectomy, severe abdominal pain related to current diarrhea illness that requires retreatment for CDI, in the follow-up period, or who elect not to continue with the study, will be transitioned to the care of a primary care physician with consultation from the local site investigator or from one of the co-investigators of CSP 596. Note, if the C. diff stool test is negative or C. diff stool test is not done at the time of diarrhea recurrence or complications, and if the participant is not treated as if they have recurrent CDI, the participant will continue to be followed on the study unless the participant elects not to continue with the study. So if this test comes out negative or is not done, for example, there's suspicion that the diarrhea may be a result of something else, say another medication, another sickness, or food related, at the agreement of the LSI participant, they may be allowed to continue the study. Lab procedures, participation of stool specimens. This has the operations manual for this. I will skip over this section as there is additional training for the lab procedures, but it is recommended that you do review this material. There will be samples will be shipped to at our request to the study to the core lab twice a year. We will send notifications of when we want you to do that, and we will provide additional assistance of when that happens for that. Protocol deviations. Strict adherence to every feature of the protocol is mandatory throughout the course of the study. A copy of the most current study protocol is available on study's SharePoint site. However, despite the best efforts of all personnel connected to the study, there may be incidents that occur that are deemed protocol deviations. Protocol deviations can be classified as major or minor. In all cases, protocol deviations, the site coordinator or LSI must notify the study project manager and the national coordinator as soon as possible. It does say or, but please contact both of us. Multiple protocol deviations occurred at one visit will be grouped together and be entered into Form 16 protocol deviation and transmitted via iDataFax to the Heinz CSP-CC. The deviation must be also recorded on the Smart Document protocol deviation log posted on the study SharePoint site. Major deviations are those that impinge on a participant's well-being, for example, a serious adverse event. Data integrity. Does the deviation render the data invalid or unusable for study purposes? Participants' participation in the study. Does the deviation render the participant ineligible for continued participation in the study? CSP guidelines, or is it not consistent with CSP guidelines? Specific protocol deviations can include consent process not properly performed prior to study procedure, informed consent documents signed after participant has started study procedure, major deviation, incorrect version of the informed consent documents signed by participant, major deviation, participant in simultaneous intervention trials, exceptions AFLA, refer to Form 01 instructions, major deviations as judged by the LSI. Required source documents, documentation could not be obtained. SAE not reported appropriately to sponsor or VA Central IRB, major deviation. Protocol deviations not reported appropriately to the VA Central IRB, see VA Central IRB guidelines. Drug accountability issue at site, study exclusionary medication taken, participant did not return study drug, participant did not take study investigational drug as directed or received wrong drug or wrong dose, major deviation as judged by the LSI, participant fails to show up for a visit within appropriate time frame, required study procedure not completed, including this visit, misrandomization, major deviation. Other deviations would be inappropriate intervention on blinding, participant repeated non-compliance with study requirements. For example, participant enrolled in study that is unavailable or not willing to be followed up per study protocol. Intentional deviation from protocol, good clinical practice, or regulations by study personnel. Materially inadequate record keeping, mishandling of sample. Stool sample was not saved or lost after obtaining this test for result preceded infection. If you do have any study deviation, please contact Michelle and myself. We will help you with them and understand if there were major deviation or minor deviation, what needs to be done with them. Deviations happen. As long as you are following all guidelines that you should be, most of them will be things that you have no control of and will not reflect poorly on you. It is better for you to talk to Michelle and myself, because we will help get you through this as quickly and efficiently as possible. When protocol deviations occur, Form 16, protocol deviation needs to be filled out. The site must report all protocol deviations rated as major according to the Central IRB policy. The site should also follow Central IRB policies reporting minor deviations. For protocol deviations, emails will be transmitted automatically to Heinz CSPCC, the chair's office, and CSP CRPCC once Form 16 is submitted to iDataFax. If the protocol deviations is due to early termination, Form 18 early termination must be completed and submitted to iDataFax. Major deviations have to be reported to us as well as the CIRB. We will help you with that. Minor deviations do not need to be reported to the CIRB, but should be reported to Michelle, to the coordinating center and the chair's office, so we can help you address those and confirm they aren't actually major deviations. If a participant completely misses a visit, every attempt should be meant to contact the participant and have them come in for their follow-up visit. Each attempt must be documented in the participant's medical record. And in the event of a missed visit, both Form 16 protocol deviation and Form 17 missed visit must be completed and submitted to iDataFax. However, participant has missed contact for 4 consecutive visits. Then a case should be reviewed by the coordinating center and chair's office to determine whether a participant should be considered lost to follow-up. Role of the Heinz Coordinating Center for Protocol Deviation. The Coordinating Center will collect all protocol deviations from each site. The project manager will keep a record of site communication, document decisions relating to protocol deviations. The biostatistician will produce data summary reports, including adherence to protocol. The Heinz Coordinating Center will check for any discrepancies in the form or evidence that the protocol is not being followed. The LSI will be notified of any protocol adherence problems. All right. That is all for this training. If you have any additional questions regarding the operations manual, be sure to contact Michelle Johnson and Neil Johnson, and we'll be happy to assist you with any kind of complications you have. After you have finished reviewing this training, please email Michelle Johnson and Neil Johnson and to let them know you have completed the training. Thank you very much. And